We are going to go over the thyroid today as part of the endocrine series. We are nearing the end. Um, Moving down the body, we did the hypothalamus and pituitary, and now we're on to the thyroid in the neck area. So for this chapter, I would like you to focus on the basic anatomy of the thyroid gland. We'll go through the macrocellular and then also the microscopic information. We'll talk in a great detail about the formation and release of thyroid hormones. I want you to understand how they are created, what different things are used to create them, and how a proteolysis process is used to liberate the final thyroid hormones. Understanding what the thyroid hormones do is key to understanding the pathology of thyroid disorders. So we'll go through those very quickly. And then, as I've mentioned with all the endocrine chapters, if you're able to diagram the feedback loops, and this is a pretty straightforward negative feedback loop system, if you're able to diagram that, you are going to be just fine for understanding the control of release of these hormones. So let's first take a look at the anatomical location of the thyroid gland. So the thyroid gland is in the anterior neck and it wraps around the trachea. So you can see it from the back as well, but that's not as obvious of a view. We're used to looking at it from the front, and it has this interesting kind of butterfly-shaped anatomical type of shape, I guess. So what you're looking at here is a scan using iodine to visualize the thyroid. And we'll see that in this lecture, the thyroid is really the only thing in the body that has a good use for iodine. So we can actually do some targeted therapies using some activated iodine, radioactive iodine, but more importantly, we can visualize it in a scan. So this scan here in C is showing you a nice healthy thyroid, and where you see the darker colors, that's iodine uptake. And iodine is essentially incorporated into the final products eventually of thyroid hormone. So this is showing you a high level of activity and a uniform coloring, which indicates healthy, active thyroid function. And this is spelled out for you on the next slide. So it's butterfly shaped. There is a right and left lobe. There is an isthmus portion, which is just a connecting stalk between these two left and right lobes. It's very heavily vascularized. There are 3 sets of veins that drain the thyroid gland, which is important because these cells in the thyroid are creating thyroid hormone, which are going to travel throughout the bloodstream. So superior thyroid veins, middle thyroid veins, and inferior thyroid veins all drain the thyroid to deliver the thyroid hormones to the body. There's also a lot of arterial connection here because this is a feedback loop system where it will be receiving products from the hypothalamic pituitary cells. So those need to reach the thyroid to be able to bind to the various receptors there and then respond to those signals by creating thyroid hormone in response. So one thing that you will see with the thyroid gland is thyroid activity is very closely intertwined with catecholamine and sympathetic activity. So not only do we have a lot of vascularization associated with the thyroid, we also have a lot of innervation. So if we take a look at the ganglion chain, the sympathetic ganglia, we can see that it lies and has a very strong attachment to the thyroid. So the superior cervical ganglion of the sympathetic trunk and the middle cervical ganglion of the sympathetic trunk are associated with the thyroid function. And just as a little note, whenever thyroid hormone is around, it allows catecholamines to bind more effectively. So if you think about sympathetic activity, when we have sympathetic activation, you'll get thyroid activation, which will enhance the sympathetic cascade. So when you think thyroid, I want you to think sympathetic. We're going to increase metabolic rate, increase heart rate, all of the things that you'll see in a typical sympathetic fight or flight physiologic response. The functional units of the thyroid are referred to as follicles. And first, you have a picture down here from your textbook showing you an animation of follicular cells. And on the top, you have a micrograph image showing you what they look like in actuality. So the follicle is referring to this kind of structural grouping of cells which are going to be active, and they will be making, hopefully, thyroid hormone, which will then be collected in the center here in this watery, viscous filled space called the colloid. So they're spherical in structure, as you can see from these pictures. They're nice little oval-shaped spheres. They're surrounded by epithelial cells, which are cuboidal types of tissue. They have a large capillary supply. I will get rid of that word supple, although it is a wonderful word. I want you to know that they have a rich capillary supply. And the cells associated with one of the other products that we'll talk about with the thyroid, calcitonin, is made by cells in this area called C cells. So that should be easy to remember. Calcitonin starts with the C. And C cells are named that because they make calcitonin. And calcitonin is the opposing product of parathyroid hormone. So the parathyroid glands aren't technically part of the thyroid. They're their own glands embedded in the back of the thyroid. And they respond to low levels of calcium in the blood. When it's time for parathyroid hormone to turn off and be inactivated, we have calcitonin, which opposes it and has the opposite effect. So that is triggered by high calcium levels in the blood. But going back to the thyroid function itself, we have these cells here surrounding this large follicular unit, making thyroid hormone, which will be stored in a precursor structure inside of this watery colloid space. So the colloid contains this precursor structure called thyroglobulin. And thyroglobulin is something that will have to break apart in order for the T3 and T4 to be liberated from this larger structure, so it can then be released into the bloodstreams. So we'll look at how this happens, and we'll go through this in a couple of different ways, but essentially we're going to be looking at bringing in different products. One of the most important are, again, these iodides. And iodides are taken in from the diet, and iodides are needed to make this precursor thyroglobulin. And globular proteins are large proteins. They're all over in the body, and thyroglobulin is a large globular protein with associated T3 and T4. Proteolysis, remember lysis means to break apart, and here we're referring to proteins. So the breaking apart of a protein is called proteolysis. So when thyroglobulin is going to give this T3, T4, by essentially breaking off these larger globular proteins to allow the liberated free T3 and T4 to get out to the bloodstream and into the peripheral tissues. So we'll see that iodides are used at different parts of this cascade. Again, we can be confident giving iodides to an individual because we only see activity with iodides physiologically within the thyroid. So iodides, you've probably heard of ionized salt, and that is typical table salt. I have a picture of it on the next slide if you've never seen a can of Morton's or any other type of table salt. That is something that's iodized so that we don't have to go in other sources for looking for a large source, essentially, of iodide. So it comes from the diet, and as long as people are having typical table salt, you can pretty much assume that they're getting an adequate level of iodide. Before table salt was iodized, we saw that it was much more common for individuals to have a goiter, which I'll describe in the next slide. So iodides, the typical American has about 400 micrograms of iodide daily in their intake through the diet. And that's way more than we need. So the minimum for kids is 150 micrograms, or sorry, for adults, kids 90 to 120. pregnant individuals 200 micrograms. So we're getting more than we need. And the good thing about taking in some iodine is that we can store it for some time so that it's available to be utilized to turn into thyroid hormone. And it is stored in places like the thyroid, but also different glands. So salivary glands, gastric, lacrimal, so the tear glands, mammary. The choroid plexus is in the brain, and that is the area associated with the production of cerebral spinal fluid. About 70 to 80 micrograms are taken up every day from the thyroid, adding to its pool so that it can create thyroid hormone, and 75% of iodine in the body is released as thyroid hormone. So we're taking in more than enough, and whatever we do take in will be utilized in some way as thyroid hormone. So this is what iodized sea salt looks like. So that means you're going to get the iodine that you need so that we can have adequate thyroid hormone. And this is our first little look at a negative feedback loop. We'll see many more pictures of this because it is important, but this is referring to the addition of iodine from the diet. So when there is sufficient dietary iodine, we have a normal functioning feedback loop. So the iodine is taken in, it is stored, it's incorporated into T3 and T4, which means the thyroid hormone will make normal homeostatic levels for balance. That's what the body needs. So that T3 and T4, they circulate through the bloodstream, and when those levels reach the necessitated homeostatic level, that will feed back to the hypothalamus, which always makes releasing hormones, right? Either a releasing hormone or a release inhibiting hormone. So we have a releasing hormone, TRH, which binds to receptors on the anterior pituitary and stimulates them to make TSH. Very good name. It is thyroid stimulating hormone. It's named for exactly what it does. So TSH binds to its receptors on the follicular cells of the thyroid, and that would cause T3 and T4 release. So again, the negative feedback just means that when levels are adequate, the T3 and T4 can feed back up to the hypothalamus. We can get the production of thyrotropin release inhibiting hormone, which would bind to receptors in the anterior pituitary so that we don't have more production of TSH. So that's a nice adequate functioning thyroid, and it just requires that there's some dietary iodine taken in. When dietary iodine is deficient, we don't have enough of the iodine to make the T3 and T4 that is necessary. So a goiter is essentially a really large thyroid. It's an enlarged thyroid. So hypertrophy means excessive growth. The cells are very big. And hypertrophy of the thyroid can happen for a variety of reasons. In this case, whenever we need more cells, we're going to get a bigger organ. So let's just track this really quickly. So we've got insufficient iodine, which means there's not going to be enough T3, T4 that's made. So that will continuously tell the hypothalamus that it needs to pump out more of its products so that we reach homeostatic levels of thyroid hormone. So we're going to have excessive feedback to the hypothalamus. We'll have a large amount of TRH made, thyrotropin releasing hormone, lots and lots of it, which will bind to receptors in the anterior pituitary, which in response are going to spit out constantly very high levels of TSH, or thyroid stimulating hormone. So the more hormone there is, the more receptors we're going to need to bind that hormone. The more receptors you need, the bigger the cell gets. So in this case, this underactive thyroid is becoming hypertrophic because it needs to grow to bind all of this TSH. And this is a continual loop that will continue feeding back and never reaching these homeostatic levels, and we'll continue to see enlargement of the thyroid until that's corrected. So you'll see goiter in both underactive and overactive cases of thyroid. In underactivity, it has to do with the excessive amount of TSH, more receptors, bigger and more cells, so you see enlarged thyroid. In overactivity, you can see a goiter because not really the opposite, but there's a lot of T3 and T4 being made. So those cells become hyperactive, and to enhance their job, they can get bigger. They're doing a lot, so just like you would exercise a muscle a lot and it gets bigger, we can see endocrine cells doing the same thing. The bigger it is, the more activity it has. All right, so that was our first little negative feedback. So what we're going to look at here is this journey of thyroid hormone synthesis. And we have a couple of different things. This is the vascular side at the bottom. So this is the blood supply side. And on the top, we have the luminal side. Lumen is a tube, right? So this is the lining of the follicle where the colloid is. So what you'll see is through a typical process using the normal pieces of the cell that we always use to make things like proteins, we will be creating this really large pro-hormone called thyroglobulin. So this lumen is going to be where we have the synthesis created. All right, so if we follow this through, we're getting iodine trafficked in through the cells because it's out in the bloodstream. So let's say somebody ate a lot of salt, or we're taking from the pool in the body. The iodine is going to be trafficked in, and it's going to be put right through this little receptor made for iodine called the pendrin receptor. And the iodine will get trafficked right through, and it'll be in the lumen. That's where we're going to have this creation of iodothyronine. At the same time that we're trafficking in iodine and adding it to the colloid pool, we have the creation of these large proteins. Remember, amino acids are going to be assembled together to make these larger proteins in the endoplasmic reticulum by the ribosomes. They will bud off and go in the Golgi, where they can be changed, things can be added or taken away, or we can just store them there. And then the thyroglobulin will be packaged in a vesicle. That's what you see here, TG, thyroglobulin will be packaged in a vesicle, come over here to the apical membrane by the follicle lumen, and just through a typical exocytosis process, the thyroglobulin will go into the colloid, and it will attach together with the iodine, and thyroid peroxidase will help in the addition of this thyroglobulin to really, really large, or including these two large proteins, MIT and DIT. So this whole thing, this is our thyroglobulin now. So we've got these two big proteins associated with it, and then we have T3 and T4, which we know are the active thyroid hormones. So this big thyroglobulin structure, this pro-hormone, hangs out in the colloid and is trafficked then back in when there is a necessity for the T3 and T4 to be released. So here we have our ionated thyroglobulin. Again, it's in the colloid. When there is a message that it's time to go out into the bloodstream, here's this receptor. It's called the megalin receptor, which is a super fun name. Here's also some little pseudopods, which will help grab this large protein, bind it to its receptor. And when we have a big structure binding to a receptor and pseudopods helping to close a vesicle around it, we call that process receptor-mediated endocytosis. So this will snap together to create a really large vesicle structure to bring in this whole big thyroglobulin structure. So here we have this really, really big pro-hormone, really large vesicle to fit it all in. Then we have a simple process where the lysosomes of the cells will help to digest, essentially, this big structure to liberate the T3 and T4 off of this backbone. So we can't release this in the body, this really large thyroglobulin. This isn't going to be able to do anything. It's really big and it's going to get stuck. So the lysosome merging with this will digest this backbone, liberate the free T3 and T4 so that it can go out through the body through its transporter. Then we can have MIT and DIT go back in through this process through the endoplasmic reticulum, be altered so we can utilize it over and over again. So iodine in, we make our thyroglobulin with our cell pieces. All this structure is stored in the colloid. Then it's trafficked back in when needed through the megalin receptor. Lysosomes come and digest the pieces that we don't need, and T3 and T4 then are released into the bloodstream through the vascular side. So it's a long journey where everything will be trafficked in, stored in the colloid, and then moved out of the colloid and digested when necessary. So hopefully that makes sense. That's the way that process works. We need iodine and we need active cell parts to make the protein structures. And then we need lysosomes to digest it. Okay, so you've heard me say T3 and T4. Just for some terminology, when people say thyroxine, they're referring to T4, and we call it T4 because it is 4 iodine atoms, which can probably help you guess why we call T3 T3. It has 3 iodine atoms. When there is low iodide states in the body, that favors the formation of T3 rather than T4 because T3 is 3 times as potent as T4. And potent means strong. So it's 3 times stronger than T4. So you get a little bit more bang for your buck. So that's why we name them T3 and T4. It is telling you how many iodine atoms are associated with the hormone. Again, as I went through in that large process, we have the follicular cells. That's what they look like. They're surrounding this watery colloid. Here is the thyroid gland under low magnification, and here's high magnification. And in this picture, the C is referring to the colloid. So that's where these things are created. So these cells, those are the ones that are trafficking in those large structures, putting them into the colloid until we don't, or until we need the T3 and T4, comes back in through that receptor, degraded, and then the T3 and T4 will go out into the bloodstream. All right. So intact thyroglobulin rarely leaves the cell. As I mentioned, it doesn't really have that much activity. We need to do proteolysis on it so that we can have the liberated free T3 and T4. So everything is stored in that colloid, and here's a cool picture on the next slide. When there is a need for T3 and T4, you'll actually see this colloid kind of like go away. These cells will contract and release their products, and we have to then kind of build up this colloid pool over again. All right, so we already saw T3 and T4. They circulate bound to proteins. Most things in your body circulate bound to proteins. The most strongly expressed protein in our bloodstream is albumin, and albumin is it's kind of like an Uber or a taxi. It's how things get around. And the stronger things bind to albumin, the longer they last in the body. Only about 0.03% of T4 goes around not on albumin, and only 0.3% of T3. The rest of it will bind to their protein rides and pop off at the tissues that they need to get to. And they know which tissues they need to get to because things move from high to low concentration. So when it gets to an organ with a low concentration of thyroid hormone, that will just necessitate the attraction of it to leave because it wants to move down its concentration gradient. So free T3, very biologically active, mediates thyroid hormone action on these peripheral tissues, and T3 also is going to help drive this negative feedback loop. All right, so as I mentioned, here is before there was any colloid release, and here is after. So you can see that these cells contracted together and squeezed out that extra colloid so that the free products could then go into the bloodstream. And then they'll relax and they'll get to work making more hormone to repopulate its colloid. All right, so when I see you next, oh geez, I don't even know when that will be. So I'll just talk about it now. A little bit of pharmacology tie-in. So if you were paying attention, hopefully you were paying attention, but who knows? I could talk all day about anything, and you have to listen, and I'm sorry for that. But anyways, iodine is necessary to make our thyroid hormone, right? So we've gotten that so far. You need iodine. If you don't have enough, the thyroid doesn't work properly, and you have a constantly going feedback loop. So when we visualize the thyroid, we know that we can make iodine radioactive so that we can visualize it. So that's cool. But there's an interesting effect. And whenever you hear that word effect, it means that nobody knows why that happens, and we're just going to call it an effect because you can't really, describe it. For hyperthyroidism, when somebody first gets a diagnosis and they're waiting for their medications to take effect, one thing that can be done is putting that patient on a really large dose of iodine. And that's what you see down here. This is something called Lugol's solution. See that guy? So this is a really concentrated way to give just aqueous iodine. And when you give somebody with hyperthyroidism, so they've got an overactive thyroid making way too much thyroid hormone, so you give them a really large dose of iodine. And for whatever reason, that really large dose stops the thyroid hormone production process at every step, and it lasts about 3 weeks. So the question is, well, why? That doesn't make sense, right? We said that if you don't have enough iodine, then the thyroid doesn't make enough. So you would think like, oh, if you give iodine, then you're probably going to make a bunch more. Well, it turns out that's not true, and nobody can explain it. So again, when they can't explain things, they call it an effect. So there's a name for it after the people who, I probably spelled this wrong, who first discovered this. It's called the Wolff-Chaikoff effect. And it just describes that when you want the thyroid to kind of chill out and stop making so much thyroid hormone, you can give a really large dose of iodine, and it will stop all steps of the production process for 3 weeks. Why? Because the Wolff-Chaikoff effect. That's why. Fun, right? Medicine is an art, not a science. So that's a nice little way to impress people at a dinner party by telling them about the Wolff-Chaikoff effect. See if they can answer your questions. All right, the other thing I mentioned is that the clinical tie-in for iodine is that we can utilize it for imaging. And this is done to visualize the size, the shape, and the activity of the thyroid gland. Again, wherever you see dark colors, that's indicating iodine uptake, which means that those cells are active and they're making thyroid hormone. So here's our butterfly-shaped gland. Here's a nice normal gland, and we wouldn't see any pathology associated with this scan. This individual has a type of hyperthyroidism, also called diffuse goiter, because it's just one really large hypertrophic gland on all sides, and it's named Graves' disease. And so it's this diffuse goiter, really hyperactive thyroid. And I want you to notice that we can visualize just using iodine. So it's just given through an IV, and it binds to the cells that use it, which are in the thyroid. And it's radioactive, so we can visualize it now on a scan. So these are really big lobes of the thyroid, so we can tell that it's hypertrophic. And we also see really, really high levels of activity. So not only is this thyroid big, but it's highly active. So that would tell you it's an overactive thyroid. Because remember, a really big thyroid can also be indicative of an underactive thyroid. So what you would see is a large thyroid, but you wouldn't see so much uptake of iodine. All right, some other things. There's something called toxic nodular goiter disorder. And toxic nodular, you've probably heard people say like a nodule on their thyroid. So nodule, so toxic nodular goiter, toxic nodular goiter. It's just one hyperactive nodule on the thyroid. Sometimes you can feel it. So it would be just like a little, I don't know, like a little bump essentially underneath the skin. The thyroid is pretty proximal to the skin, so you can feel it if you try really hard. In males, if you ask them to swallow, it's right below the Adam's apple. Women don't have an Adam's apple, so you can't do that trick with them. You just have to dig for it. But anyways, you can sometimes feel this little nodule, and that means it's a very hyperactive nodule. And this is the rule in endocrinology in general. Whenever something gets bigger, it's going to make more hormone, period. That is a very good rule, and we'll learn a lot about that in pathology. So what you're looking for here in toxic nodular goiter is hyperactive nodules. So in this place, in this tissue, we see one side of the thyroid looking pretty physiologically normal, and over here we have some hyperactive spots. Same thing over on this one. This is toxic adenoma. An adenoma, so it's not just a hyperactive nodule. An adenoma, adeno means organ or gland. And an adenoma is a benign growth of an endocrine tissue. So in this case, we would just have an overactive benign growth. As I just said, whenever you have a growth on an endocrine tissue, you're going to get way, way more hormone than you typically would. So you see a really large area of activity, and this is a benign issue. So is toxic nodular goiter, which means once you take out those areas, then the disease goes away. We refer to these little spots of high activity as hot spots. And there's one thing that I want you to know about that. A hot spot, so if you send somebody in for imaging and you found a hot spot like this, that's good. That means it's benign, because benign growths make more hormone and they're highly active, and you can explain it and you can take it out and it's treated really easily. If you saw, however, an area of, hey, my cat's scratching my couch, get out of here, jerk. All right, sorry about that. If instead of black, you saw white, that's called a cold spot, and that is not good news. The reason why is when you have a malignant growth, it's not just making more hormone, it's different than the parent tissue. So a cold spot is 10 times more likely to be cancerous because it doesn't do normal thyroid things. So that's what I want you to remember about imaging, and you'll revisit in radiology and clinical diagnosis. Hot spot, high activity, benign. Cold spot, low activity, that's not good. When you see something like that, you can aspirate it. As I said, it is proximal to the skin, so you could do a needle aspiration for a quick pathological biopsy to examine the cells to see if it's thyroid cancer or benign growth. So iodine is a really great tool to look at the pathology, to visualize an organ, not only its size and shape, but also its activity, and tell you a lot about that patient. Okay, so just for the couple other things, the rest of the lecture, we'll just be talking about thyroid activity and thyroid hormone activity. All right, so if you understand the physiologic effects of thyroid hormones, what I just mentioned with like looking at imaging, looking at what's going on with somebody's thyroid activity, it should all make sense. So I want you to remember that thyroid hormone is a metabolic hormone. It increases metabolic activity. It will do pretty much everything that you see in a sympathetic response. So here's a thyroid cell. It's got some TSH receptors on it. And this is talking about increased thyroid hormone. We're not going to talk about this right now, diabetic ketoacidosis. I'm going to change that picture actually so that we don't talk about that. But we're going to see all of this activity mirroring what we would typically see in a sympathetic response. So we see that, this is from your book, make it a little bit bigger so that we can look at it together. When we talked about the thyroid hormone, even though it's not a steroid hormone, like cortisol and things like that, and anything that comes from the gonads, we expect that to go into a nucleus and do transcription translation because they're highly fat soluble. And that makes sense. One of the things that breaks that rule, which is why we went over this in the first lecture, is T3 and T4. It has an intracellular receptor in the same way that steroid hormones do. So here is our receptor for T3, T4, thyroid hormones in general bind to thyroid hormone receptors. And when we have intracellular receptors, that means that this will cause the reading of this DNA. We're going to look in here for a recipe for a protein that we want, and then we're going to copy it, and then we're going to make that protein. So in the same way we see hormones that are highly fat soluble, like our steroid hormones, go into the cell, we will see T3 and T4 do that. They do bind to intracellular receptors that are on the DNA and read the DNA and make new proteins. So these are responsible for a lot of different activities. Again, I want you to think of it as metabolic. Everything that you would see in a typical sympathetic response goes up, but all activity is going to go up. We're going to use glucose, use fat, increase mitochondrial activity, increase sodium-potassium pump activity. Protein synthesis goes up. Basal metabolic rate goes up. Everything will be increased. It is a hormone that increases metabolism at every level, cellular and macrocellular. It also has this tie-in, because of the sympathetic chain ganglia being right near it and the strong innervation, with increasing cardiac output. The reason for this, again, is whenever thyroid hormone is around, it encourages catecholamines to bind more effectively. So we'll see all of those things in a sympathetic response also be amplified by thyroid hormone. They work together. So that should make sense about why somebody with a hyperactive thyroid tends to be underweight. They eat a lot because they're trying to keep up with whatever their brain has set for their homeostatic level of caloric intake, but they maintain a low body weight. They run hot. They can have eye symptoms we talk about more in pathology. And then when you have an underactive thyroid, those things are opposite. You tend to run cold, and there tends to be a favoring of weight gain. So intracellular receptors, they read the DNA, new transcription translation. Two other things that I want you to know that are really important. You noticed on one of the slides, hopefully, that pregnant women need a little bit extra thyroid hormone. Thyroid hormone is absolutely necessary in the first trimester of pregnancy. And the first trimester is important because that's when everything is being assembled. After the first trimester, the fetus just gets larger. So everything is being assembled during that first trimester. If there's inadequate thyroid hormone, there's a disease that's associated from that called cretinism, where there is abnormal long bone development and irreversible brain damage. So you only need it for a very short period of time, but it's critical during that period of time. So it's needed for growth and for the formation of the central nervous system. All right, so this page has the cardiovascular effects. Directly, what it helps do, again, increases tissue sensitivity to catecholamines. So catecholamines, if you don't remember, are your dopamine. I like you to remember little mnemonics. So I like to say the cat lives in the den, D-E-N. Cat for catecholamine. So dopamine, epinephrine, and norepinephrine. Those are your catecholamines. So whenever those things are around, they're going to bind more effectively to their receptors, those alpha and beta receptors. So that's one thing that they do, and that's a little bit more indirect because they don't directly cause that. It's just whenever they're released into the bloodstream, that's the resulting effect for catecholamines to be more attracted to their receptors. The other thing that it does that is extremely direct is it increases calcium uptake and release of calcium from the sarcoplasmic reticulum. When we go into the heart, we'll talk about this in a lot of detail, but you also learned about this in the muscle chapter when you're learning about muscle cells and muscle action potentials, how we had eventually calcium being released from the inside of the cell. And where calcium is stored is in the sarcoplasmic reticulum. Why that is really important is that's how your heart runs. Epinephrine binds or norepinephrine binds. And the reason that we have a contraction of cardiac muscle is because we liberate the calcium from the internal sarcoplasmic reticulum. So when thyroid hormone's around, it increases that. So there's more calcium and more liberation of calcium from the sarcoplasmic reticulum. That will result in an increase in cardiac output. Heart rate goes up, stroke volume is increased. Stroke volume is how much blood is ejected each time the heart beats. And a typical stroke volume in adults is 3 tablespoons, which is a nice measurement, but that's about 15 milliliters. So stroke volume goes up. That tells you that the heart is beating stronger. So the speed will go up, the force of the contractions goes up, and the time between heartbeats is called diastole, because you can relax when you die. That's how I remember it. So diastole is when the heart is not beating. That's what you measure in a T wave. So that time goes down. So the heart doesn't rest as much. So the heart's beating stronger, faster, longer, and it's not resting. There's also something called pulse pressure. Pulse pressure is the difference between diastolic and systolic pressure. So you might know that 120/80 is an average blood pressure in healthy adults. If you take the difference between that, that's called pulse pressure. So if you're super good at math, what's 120 minus 80? 40. Very good. I believe in you. Great job. So we're going to have a widened pulse pressure. So instead of having 120/80 and a pulse pressure of 40, let's say that person's blood pressure is going to go up to 150/70. All right, so that's a much larger pulse pressure. So we're at about like 80 then. That also is going to be associated with a decrease in total peripheral resistance, which we call TPR. We'll learn about that in the blood pressure chapter. But if your heart rate goes up that high, your vessels have to be able to let that blood in. So they have to become compliant. So we'll have a decrease in peripheral resistance, because if your heart is beating against a really resistant vasculature, that's how you get heart failure. So it decreases TPR, bigger pulse pressure, everything heart related is going to go up. Calcium is going to be released from the sarcoplasmic reticulum. The heart beats more, longer, faster. Okay, the metabolic effects I've mentioned. O2 consumption goes up. The heat production goes up. Mitochondrial uncoupling goes up. Lipolysis of fat goes up. Protein turnover goes up. Utilizes our protein pool. So not only do people with a highly active thyroid, they start to lose fat. Well, where's the other place that you have a pool of protein that your thyroid can then get your body to tap into? It's the muscles. So once you have fat loss, there can be a resulting muscle wasting that goes along with this. So it's a good activity. We just don't want it to go on forever in hyperthyroidism. So here's a graph. Very good, right? A graph. So here's thyroid hormones per day on the x-axis and basal or baseline metabolic rate on the y. And it is showing you that the more thyroid hormone is present in milligrams per day, the higher the baseline or basal metabolic rate. So It is a hormone of metabolism. Respiratory effects increases the utilization of oxygen and enhances the supply. And it does that by making changes in an increasing way to the respiratory rate, to minute ventilation. So that's going to change what's called your tidal volume. We'll learn about that later on this semester, but how much air you take in per breath. Ventilatory response, hypercapnia and hypoxia. So it helps you, hypercapnia is too much CO2. So it enhances the response to too much CO2 or to not enough oxygen. And it also increases your hematocrit. Hematocrit is the hard-packed red blood cells at the bottom of a test tube when you draw blood. And the normal amount, like the perfect amount, should be 45% in a test tube from a blood draw. So you would see the hematocrit going up. There would be more red blood cells. And that is a direct result of a product called erythropoietin, or EPO, produced by the kidney. Whenever EPO is around, you get more red blood cells. So that's how we say it increases utilization and supply. It's going to make you breathe more. It makes you more efficient in responding to too much CO2 or low oxygen. It increases the amount of circulating red blood cells. So it is highly metabolic. If you're doing all that activity with these different metabolic effects, then you're going to need to be able to utilize oxygen efficiently. Skeletal muscle effects. We need some thyroid hormone, as I mentioned, to have normal function of skeletal muscle. It's extremely important, though, in the development of the muscular system. So it's needed during development, and it's also needed for general skeletal muscle effects in adults as well. Glycolysis and glycogenolysis are increased by lots of excess T3, T4. Remember, lysis is to break apart. It's like the breaking down of like glycogen and glucose. Glycogen and creatine phosphate are reduced by lots of T3 and T4. Muscle can't phosphorylate creatine. Creatinine is a product of that. We talk about that in the kidney chapter. That is a way to look at kidney function. It has a lot to do also with the wasting of muscles. We'll talk about that more in the future. All right, we're almost done with this. As I've mentioned many times, the autonomic nervous system effects are synergistic with the catecholamines. So whenever you have thyroid hormone, we've already mentioned that metabolic rate goes up. It's going to mirror our sympathetic response. The more thyroid hormone there is, there can be an increase of beta receptors on the myocardium to support the increased heart rate that you would see in high levels of thyroid hormone. Okay, as I've also mentioned, it is critical, or thyroid hormone is critical for the first trimester for fetal development. The fetal thyroid axis, so that means the fetus's own thyroid, becomes functional at mid-gestation, so about the 20-week point. So before then, it needs to be provided by the mother. And remember, adults need about 150 micrograms of iodine per day. Pregnant women need about 50 extra, so they need 200, and that's to provide access to the fetus to aid in the neurological and long bone formation. If the thyroid hormone is not present, again, that leads to a disease called cretinism, characterized by mental retardation and short stature. This is also referred to as congenital hypothyroidism. And congenital means in utero, essentially. Con means with, and genital means two genitals put together, resulting in a pregnancy. So that means everything genetic went fine. However, there was some sort of developmental abnormality. All right. Okay. As I've said, pregnancy is going to require more iodine. Women need to make more thyroglobulin, more T3, T4. All women during the first trimester, they're going to have an increase in thyroglobulin to provide for the embryo at that point in time. You'll see T3, T4 go up, and then the free T4 will decline over the pregnancy in people with hypothyroid disease. And when you think about women who are pregnant, you usually think of them not taking any medications whatsoever. But when there's hypothyroidism in pregnant females, not only do they stay on their medication, but the dose will have to be escalated as the pregnancy progresses. But every pregnant woman should have their TSH checked. It's easy to supplement thyroid hormone for individuals who don't have enough, so that we can ensure the embryo and fetus develop appropriately. Bone development, as I've mentioned, is important. Development in the early fetal stages. The earliest bone formation is called endochondral ossification. If you've ever had to learn about this, it's just a dream. But essentially, there's a cartilage matrix that starts to become more hard and more calcified. We form our compact bone then. We start to draw the epiphyseal line, the disc. We make a medullary cavity at that point in time. So this all happens really, really early on in a pregnancy. So in order to have normal endochondral bone development, thyroid hormone is necessary. It helps linear or long bone growth, maturation of those epiphyseal, like growth plate centers, and it's also really important with adult bone remodeling because of the C cells in the thyroid that help make calcitonin. Calcitonin is important because when there's high calcium in the blood, whoops, it puts that extra puts the extra calcium into the bones. So you need a healthy thyroid with healthy C cells. When you have a lot of calcium in the blood, calcitonin will shuttle it to the bones. So it makes your bones nice and strong. Very important. So thyroid hormone, how magical. We've learned so much about it. All right, when there is this in utero deficiency and the resulting possible cretinism, when we look neurologically, the decreases are growth of the cerebellar and cerebral cortex. So the cerebellum, we're starting to recognize in neuroscience, is a lot more important than we thought that it was. We pretty much thought that it was the balance center and that was it. But it's very important to normal integration pathways for movement, and it shows a lot of damage in disease states. The cerebral cortex, the cerebrum is the big part of your brain. That cortex means bark in Latin. So it's the outermost covering of the rest of the brain, essentially. And those are where we store a lot of critical activities. And that's also how we think and make decisions and try not to be impulsive and learn rules. Decreases are also seen in the proliferation of axons. So proliferate means to grow and spread. There's a fun finding in neuroscience that the number of neurons is not correlated with intelligence, but the number of synapses that you have is. So the more proliferation you have of axons and resulting sprouting with dendrites or axon-axonal connections, the more things can be stored and the more efficiently the brain works, and then the higher intelligence goes. Also decreases in branching of dendrites, synaptogenesis, which means the creation of synapses, myelinization, to help ensure that we have good nervous function and messages can be sent from point A to point B, and then cell migration as we're getting brain development. Also, we saw irreversible brain damage. So if you're getting damage to the cortices and the axons and the synapses and myelin, that is not something that is reversible at this moment in time with current medicine. When there is an adequate level of thyroid hormone in the blood, the other things that the brain seems to do is respond in a more wakeful manner, more alert, which has to do with your reticular activating system. People are more responsive to various stimuli when they're given various tasks in the lab and they have high levels of thyroid hormone. They can attend to multiple things at a time and they respond better on cognitive function tests. On auditory tests, they are more aware of when they're hungry because thyroid hormone has a lot to do with calorie expenditure. Their memory's enhanced and learning capacity. So thyroid hormone, who knew it was so important to our development and to our everyday function in a metabolic in a cardiovascular, respiratory, and nervous system activity. All right, guys, final things. Let's just make sure we're super good with our feedback loops. And if you know your feedback loops, you're going to be great, I promise you. Here's a brain, hypothalamus, pituitary. Hypothalamus always will make a releasing hormone, and the pituitary, the anterior adenohypophysis, will make a tropic hormone. All right, so here is our feedback loop. Everything you need to know is here about the feedback loop. It's beautiful and it's color-coded for you. And it's also showing you when things are hitting the general bloodstream by turning red. So the hypothalamus makes its releasing hormone, thyrotropin releasing hormone, TRH. TRH binds to cells in the adenohypophysis, which in turn makes its product thyroid stimulating hormone, TSH. What a great name. It's named for exactly what it does. It will go into the bloodstream. It will bind to those follicular cells and stimulate them to start the production of T3 and T4, which we've learned is stored in the colloid, and all we have to do is traffic it back in through that little megalin receptor. We're going to dissolve the backbone to liberate the free T3 and T4 off, so that the free T3 and T4 can enter the bloodstream, increase catecholamines, help with growth and development, increase metabolism, and do all of the magical things that it does. T3 and T4, those will help house this negative feedback loop. So when T3 and T4 are adequate, we will have a message to the hypothalamus from T3, T4 that we have adequate levels. The hypothalamus will make thyrotropin release inhibiting hormone, which will bind to cells in the adenohypophysis or anterior pituitary and block them from making more TSH. And that is your feedback loop. I would suggest as soon as you get your exam, just drawing that feedback loop right on there, because I will be asking a lot of questions about it. This is another picture showing you this exact process. Again, a hypothalamus, TRH, binds to the anterior pituitary. Anterior pituitary cells release TSH. TSH goes to the bloodstream, binds to the follicular cells. T3 and T4 are liberated from the colloid, digested off of their backbones, go in the blood, and then hopefully are just released until we have homeostasis reached. And then, hopefully, that feedback turns off release and we get thyrotropin release inhibiting hormone. And that is everything you should know for this class about the thyroid. Enjoy. Final question. Iodine, it's going to seem really easy, but this is from the endocrine section of the boards. It will seem easy because we just talked about this chapter, but when you take the boards, you will be sampling from a pool of about 1,000 questions that will pop up in random order. So it won't be this easy, but we should know that the thyroid gland is the only gland in the body that utilizes iodine. Thank you for listening. Everyone have a great day. We'll see you soon with adrenals.